Good afternoon. My name is Hope Frost, and on behalf of SBK Healthcare, I am delighted to welcome you to the Art of Consultations for Diabetes Nurse Specialists webinar. I'd like to thank Abbott for sponsoring this webinar and making it possible today. So it is now my pleasure to introduce you to your webinar chair, who is Sue Down, and Sue is a diabetes nurse consultant and co-vice chair of the Primary Care Diabetes Society. Hello, Sue.
Hi, Hope. Hi. And lovely to see everybody here this afternoon. There's a lot of names on the list that I recognise, so welcome to all of you. And yeah, thank you to the SBK team for inviting me to chair this afternoon. This is such an important topic, being able to hold really good consultations with our patients, particularly in the last 2 years that we've been through. And so it's my great pleasure to be chair to Geraldine this afternoon, who, as you've heard, is the Type 1 service lead in King's College. Hi, Geraldine.
Hi, everyone.
She's got a great passion working with people with Type 1 diabetes and all of the technology that goes with that. But also, she's got a great interest in motivational interviewing and CBT, and you're going to help us go through the art of conducting a really good consultation this afternoon. And like you've already heard, lots of questions, please just bring them in, put them in the Q&A, and I will be putting them to Geraldine either throughout the session or at the end. So we're quite happy to do either. So do keep sending them through. And yeah, over to you, Geraldine.
So thank you, SBK, for actually inviting me to speak today. It's a great pleasure, actually, to discuss this really important topic, as I think we'd all agree it's something that we never quite fully master and always develop in. So the agenda for today is around a bit of an introduction of where I've come from, you know, what I do, and a little bit about how I've come to maybe do this talk today, the factors to a successful consultation, bringing in some of the psychological aspects and thinking about how we speak to people with diabetes and the language that we use. I'm touching a little bit on some of the kind of key skills that I use for data interpretation. And I've also got an example, there's a couple of examples actually of consultations that I'd like to share with you. So that's the kind of agenda that we're looking at. And the learning objectives for today are really to kind of improve our confidence with regards to the consultation, goal setting, and our communication skills. And again, that empathy that we're going to share with the people that we're seeing. So I'm going to get Sarah really just to do a quick poll with you, and I really wanted to see, first of all, how confident do you feel in conducting difficult consultations? So this is the consultation where maybe you've got somebody with quite a lot of complex issues, psychological issues. How confident do you feel in achieving that? So if you wouldn't mind just answering that poll for me. And at the moment, I can't see any poll results, so hopefully somebody will let me know once those are up.
Hi, Geraldine. We've hit 74% of people responding. Shall I end the poll and share the results?
Yes, please. Oh, fabulous. So actually not too bad. So it's some people that maybe still developing that skill, and some people that are relatively confident but feel that, you know, there are always more skills that we can develop, isn't there? So what I'd like to do next is I've got another question for you. So again, if you can just poll this in the same way, have you ever had any formal consultation training? And Sarah, again, or Sue, when we've got a good response, if you could just share that with me. That would be great.
Right, we've hit 81% response, so I'll share it.
Lovely. Okay, and in some respects, that's what I was possibly expecting to see. It's really interesting, isn't it, that a large percentage of what we do, and we actually haven't had any kind of specific formal training for consultations. So this is a little bit about me. And when I was asked to do this presentation, I kind of thought, well, you know, actually, this is a really difficult presentation to do. How do you put down on paper what you do verbally, you know, with the communication, with the body language that you do with people? And a lot of it has been self-learned, I've got to say. You know, I've been a DSM now for just over 20 years. I'm a committee member of the Diabetes Technology Network meeting. I run the Type 1 service here at King's College Hospital. King's College Hospital, which some of you may know, is a large tertiary referral centre. So 60% of the people that we see are generally out of area for us. And for those that come into our service are primarily coming in due to problems with hypoglycemia unawareness, psychological or issues, or looking to advance technology. So we have quite a large cohort of people with type 1, quite a large cohort of people with technology. And I suppose for me, because of the speciality that we have within the service, technology and psychology have been very much a kind of passion, and something that I like to kind of keep improving within my own management. But like you, I've had no formal consultation or psychological qualifications. So it's all kind of learned experience. And I suppose what I have been very lucky in is that I have worked with some fantastic people within the field. So hopefully I've been able to pick up some of the hints and tips from them, really. And this is, you know, in some respects, how I would describe possibly some of the consultations that we can have. So we have some really good consultations, and we kind of know that information has really landed with people, and we see that when they come back. We sometimes don't always know if we've had a bad consultation. You always get the feeling if information hasn't landed with someone, you're not getting that body response back. But sometimes there aren't always the cues that it was a bad consultation. But we certainly remember the really ugly consultations, the ones that have gone maybe particularly badly. And I'm going to share one of those with you in a little while at the end. But again, what I'd like you to do, so this one's slightly different. This is a Slido question. So if you could hold your camera, mobile phone camera, up to the QR code, what I'd like you to type in is, what do you feel are the most important success factors for a successful consultation? So I thought after lunch, we'll get some of you working as well a little bit. So again, if you're not familiar with Slido, you've got the link there, and you've also got the QR code. So you can just hold your camera up to the QR code. It should find the QR code, and then brilliant. So we've got honesty, being open, the language that we use, and then I'll say listening, really listening, the rapport. So being clear, the setting that we're in, the two-way communication, open listening, agree, the relationships. We'll just get a few more of you coming in. So the patient engaging, and that can sometimes be difficult. So how do you know that they're engaging, or how do you know sometimes that they're saying the things that they just want, you know, they want you to hear? Open body language, the trust, I think that's really important, being approachable. Fantastic. So I think we've got enough there. If Sarah, you wouldn't mind giving the screen back to me. Or do I need to share again?
Take it over, yeah.
Yeah. We've got some more coming in now as well. And so if you could just let me know that you can see. So I've just put some bullet points there of what I feel are, which a lot of you've brought up. I think preparation for a consultation, having enough time to review the patient's notes, to review and understand what some of the issues have been in the past. The environment that you're holding that consultation in is really, really important. You know, you're not constantly being interrupted. It's a comfortable environment for the person to share maybe some really personal information with you. Time, making sure that you have enough time in that consultation, you're not being rushed, or you're already running behind and feel that you've got, you know, 2 or 3 people already waiting. Meeting and listening, and some of you had put that up on the screen, and it's really meeting that person and listening and showing genuine empathy. I think is really, really important. The agenda, so what's your agenda for that consultation, and what's the person's agenda for that consultation? And again, are they the same, and do you need to book in maybe more than one consultation to be able to meet everything that's on that agenda? What are the expectations of the consultation? Someone said again to keep to the agreed plan. I think honesty about, you know, what you are physically able to achieve. So if we agree a care plan, it's really important that we follow through with that. And it's really important for them to know that we are there to provide a service. We are there to offer support for them. You know, we're there to assist them and guide and support. That's part of our role that we're here to do. And the other thing that I put there as I think is a really important successful factor is confidence and knowledge. So when you have confidence and knowledge in the skills, in your consultation, in the knowledge around diabetes, in the knowledge in data interpretation, I think, again, that's really, really important. And I'm going to share one of the tools that I use here at King's. And it was something that was developed by the Health Innovation Network. And it was done through Guy's, St Thomas's and King's College Hospital with other institutes within South London. And this is a consultation tool, a type 1 diabetes consultation tool. And it does come with a user guide. So if this is something that you'd like to possibly adopt, you can look at the link. Again, you'll have all these slides with all the links and resources. It has videos around consultation skills, around psychology, asking awkward questions and how to use this tool. But I've got to say, this really has changed my consultation, and I didn't think it would change it in the way that it has. One of the questions that's asked on this tool is just basically, what would you like to discuss at your appointment today? And I kind of thought, well, do we not do that as part of the consultation? When anyone comes in, I ask them how they are, what would they like to discuss? But I think it was the way in which we were asking, and people actually hadn't had time to think about what they really wanted from those consultations. And when we first introduced this tool into our clinics, people often come with this part actually blank. They fill the rest in, but this part was often blank. And when we asked people, they didn't know what they were allowed to ask for. They wasn't always sure what the agenda of the consultation was for. And once people had kind of gone through the service a few times, they found this really helpful. It gave them a few minutes while they were waiting in the waiting room to really think about what they wanted to achieve from the consultation. So you've got that first question where, what would you like to know? And then you've also then got the kind of really important questions that, you know, we all want to be able to gather in consultations around how many hospital admissions, what education, severe hypoglycemia, hypo-awareness, and the goal score, which you can see there as well. And you've got there your care processes as well. So again, as part of our agenda for the consultation, we've got all the right information that we need to collect really at most consultations. But again, one of the other key questions that I think this tool has is the DDS, the Diabetes Distress Score. And this is a tool that's a validated tool that's used quite widely. And basically it just asks, living with diabetes can sometimes be tough. There are many problems and hassles concerning diabetes, and they can vary greatly in severity. Please consider the degree to which each of these 2 items below may have distressed or bothered you in the last 4 weeks, and circle the appropriate number. So the person would then look at the questions of feeling overwhelmed by the demands of living with diabetes, 1 not being a problem at all, and 6 being a very serious problem, feeling that I am often failing with my diabetes routine, 1 not a problem at all, and 6 a very serious problem. And then we'd look at the average, and basically anything over 4 is showing significant diabetes distress. And again, the link that I showed you would guide you a little bit to what the next steps are and whether further assessment needs to be done, particularly with people with very large amounts of diabetes distress. And when we first introduced this as part of the tool and as part of our service, there was a bit of uneasiness across the team. I think, you know, the best way I could describe it was people felt that they were going to open that can of worms and often then not know what to do with the information that was there. So, you know, and it's very difficult, isn't it? Because, you know, there is a clear relationship between diabetes distress and HbA1c. And so it's really important that we kind of use that link and really delve deeper to see what the underlying causes are. And this is part of that tool. And this part was actually developed by people with diabetes themselves, people with type 1 diabetes. And it's a bit like a dartboard, if you like, and they chose the colours as well. And basically, if someone's got high diabetes distress and high HbA1c, again, you can link in that, you know, in really to deal with the high HbA1c, we have to look at where the diabetes distress and what's possibly causing that. So again, this is quite a good visual tool that you can use. And as I say, we really have to go to the root cause. You know, the symptom is often the reduced number of boluses, the actual diabetes distress itself, or the HbA1c level. But the root cause can actually sometimes be things in or outside of diabetes. It can be depression, in which case we need to direct that person in the right place for that depression management. It could be around burnout and acceptance of their diabetes. It could be about things outside of diabetes, such as work, school, relationships, financial issues. It could be things that we can deal with, like fears of hypo, weight gain, fears of complications. Even I had somebody recently in clinic, which was around just pure lack of skill and knowledge around a certain area, particularly with exercise for them. So again, it's really getting to that root cause so that we can deal with that diabetes distress to then improve the glycemic management. And I think it's right to make the following assumptions: that the higher the HbA1c, the more likely that the patient has some underlying psychological problems. And the bare minimum of what we should be doing is asking that person, you know, what is going on? So when they score on that diabetes distress scale, the first question I'll often ask is, you know, tell me a little bit about why you've scored the levels that you've scored, why you've marked the levels that you've marked. And we really have to think about psychological problems as a complication of having type 1 diabetes. You know, as much as we're aware of renal function and eye disease, we should be aware of depression and diabetes distress and should be screening in the same way as well. So I really wanted to just share this case study with you. It's a 19-year-old with type 1 diabetes for 12 years. She was really struggling over the last 4 years. HbA1c over those last 4 years was generally above 10%, but the reading today in clinic was at 13.6%, which was 125 millimoles per mole. And she'd actually had 4 DKAs in the last 3 years. And to her, nothing was working. She was really getting frustrated. In her words, she felt she was going to come to her clinic appointments, be told off, go off again, and nothing was changed. And what you can see here is that consultation tool built out. She was actually on an insulin pump as well at the time. So there was huge concern around someone having DKA on an insulin pump with that high of a HbA1c. And you can see on the right-hand side how we were aiming to link in the diabetes distress and the high HbA1c. So I think what we had to do in these kind of quite difficult consultations is look at the green shoots. What are the green shoots? What are the areas that we can look at to try and see if we can engage, empathize, really meet that person so that we can understand and see if there's any movement that we can move them from where they currently are at. Well, the green shoots was that she was at the consultation and she was attending her appointments. She was doing some measurements on the download. So really, I wanted to find out, why do you do the measurements that you do? And she was asking for help. So apart from that question, that open question at the beginning, she wanted things to change. I really had to kind of delve in and use some of those consultation skills to really find out why she wanted things to change and what would be different if they did change. And what we come up with was, after kind of really asking lots of open-ended questions, really, that there was lots of issues around bolusing and timing. When she was out, she didn't want to be bolusing in front of her friends if she was out for a meal. She wanted to forget around her diabetes. And we kind of really scoped and planned what we felt could be happening for her. And we kind of drew it out and kind of looked at each step. And, we discussed, you're out with your friends, you'd have something to eat, you'd avoid insulin. How do you feel at that stage? She'd often say, well, actually, I felt quite guilty. I knew that my blood glucose levels would rise, and I'd feel quite guilty around that. And that constantly stayed then in the back of her mind. She didn't want to see the highs. She didn't do a blood glucose test, but knew just through her symptoms or because of what's happened in the past that the levels would be high. She'd give a random bolus with the pump. And then the anxiety changed from having high blood glucose levels to the fact that she'd given a random bolus that her blood glucose levels were going to fall. And then she'd be constantly thinking, I better eat something soon because my blood glucose levels are going to be low. So she'd then have something without any insulin again and find that her blood glucose levels were back up where they started, all the time feeling completely fed up, guilty, and feeling that she'll never have control of her diabetes. So we discussed actually that this was somebody that, in the process of what she was doing, she still had those fears. She didn't forget around her diabetes. If anything, she felt more about, she was thinking more about her diabetes. She was probably doing the same amount of work that she'd need to be doing, but the insulin was in the wrong place. It wasn't where it needed to be. It had to be upfront with the food. So we talked a lot around timing of the boluses, not avoiding or missing boluses, using a bolus calculator. So this was a lot of the discussion that I had. And again, I feel it went as a good consultation because as she come back, things had improved. She's actually got a HbA1c sitting around 8.5% now. So she, things had moved. Yes, it may not be where we want it to be, but actually given her history, it's far better than where it had been for many, many years. And this is something as well, this is quite a good tool that I've picked up over many, many years. And a lot of you have probably seen this before. It's the stages of change. And I often try to think, where are they with regards to making a change? Are they still at that contemplation stage? In which case, for me, it's really working out why they want to make that change and really thinking about the ambivalence that's often being, the good and the bad devil on the shoulder, kind of really what's kind of weighing the decisions at the moment and how can we look and explore possible reasons for making change and what those benefits will be. And then it's looking at the how. So if we're going to make those changes, how are we going to make those changes? Do I then have to provide additional education? I ask permission for that as well. And what are the barriers for those possible changes being made? What has been the barriers in the past? And again, always thinking about a possible plan. So when we go to make those changes, we always know that there will be times of relapse. So what's going to be the plan? What's going to be the support network that's in? So again, around the questioning that I often ask people and the open-ended questions and the kind of delving deeper, if you like, that's often that stages of change that I'm thinking about. And this is a good tool that it's quite a basic tool. We've already used it today, but how confident are you of the change that you're making? Why did you score this and what's going to motivate you? What will stop you getting to 10 and how will that prevent, how will you prevent that from happening? So again, this can be really good to look at what those possible barriers for those goal settings can be. And I think, again, when we're thinking of consultations, we've really got to think of the language that we use. So I really try to avoid using test. I think test associates with something's got to be right or wrong, and it associates whether the actions that we've done in the past, whether we've passed or failed at what we've done previously. Where measurement is very much looking at the forward, it's thinking, what can I do now to get my blood glucose where I want them to be moving forward? Trying to avoid things like control, talking about glucose levels, trying to avoid things like good or bad, high or low readings. So again, I'd really suggest that, if you haven't read this document, it's a really good document to read so that you can really think about diabetes in the context of the person that we're speaking to, and about the language that we use. And again, I think this is something that we should be adapting in all areas, not just in the consultation, but as we're speaking to colleagues, and really call out people if you find that they're using the inappropriate language as well. So I wanted to touch upon interpreting the data. And I think, again, this can be really, really challenging. We often find that, there's so much information to look at. So again, I do believe practice makes perfect. And I wanted to share some of the key aspects of looking at data with you and part of that consultation. And again, what I'd advise you to do, not necessarily now, but maybe in your own time, is really think about how confident you are at interpreting data from a download. Could you come up with a hypothesis of looking at a download within 90 seconds? And how confident you are across different technologies. So whether that be Libra, CGM or pump. And again, I'm going to share some resources with you at the end that will support some of that. And so go through those resources, maybe in a couple of months, do this self-assessment on yourself and see if you are changing and what additional support you're needing. But the first thing I'm often thinking about when I'm looking at somebody's download or data is it structural behavioural issues? We're going to touch upon structural issues in a moment. These are really the settings or the doses that the person is using. But again, it's really kind of split into what's structural and what's behavioural. So the number of blood glucose measurements or scans that they're doing, again, we know that people that are doing finger prick tests around 7 times per day, people that are doing scans around 13 times per day are more likely to get HbA1c nearer of that 7%. Does that also match the number of quick acting injections or boluses that they're doing? Are they timing of their insulin to the food where they need to be? Are they overriding possibly the bolus calculators that you're using? Are the frequency of set changes right if they're on an insulin pump? And are they over treating the highs or lows? So it's really important that we don't adjust settings that are due to behavioural issues unless those behavioural issues are being driven by incorrect settings. And this is what I call HbA1c, because I think really if the settings, and I'm thinking about bolus calculators, pump settings, and again, you can use all of these tips for people that are on multiple daily injections as well. If the doses are not correct, then often people adjust their behaviour to adapt to that. And actually, this can be a way of gaining back some HbA1c. So that when we're looking at the calculations, I always look at the total daily dose. Is the total daily dose what you'd expect it to be for the weight and for the HbA1c level? What I tend to find with the total daily dose is actually that doesn't change that much, and it's where the insulin is being distributed. So I'd use that as a starting guide, but really it's the next couple of aspects that I'd look at. What's the background to bolus split? So if it's somebody that's having a typical carb intake of 150 to 170 grams per day, I'd expect the quick acting to long acting split to be around 50 to 50%. If it's somebody that's high carbon, again, you'd expect that percentage to change. So again, the more dominant percentage would be with bolus, maybe nearest to 70%. So again, all of these slides you guys can have so you can look back at them in a bit more detail. I always recalculate the insulin in every consultation according to the total daily dose. And it really helps me to have a look and think about, are these the settings that I would expect to see? And there was a really good paper done by King et al. It was a meta-analysis that's done, which is why we're using the kind of carb ratios, insulin sensitivity factor rules that we're using, and the basal to background split. And the idea of these kind of calculation rules is really that we have an aggressive bolus but soft correction. So that aggressive bolus in some respects is safer as it's been buffered by the food intake that the person is having. And we know that most hypos are often due to correction hypos or stacking of insulin. So again, it reduces that risk. And what I've done to the right-hand side here is really just share with you how I would do that recalculation. So if somebody was on 50 units per day, for example, I'll do 350 to work out the carb ratio, divided by 50 to find out what their carb ratio would be. And for that person, it'd be 1 unit to 7 grams. The insulin sensitivity is the 120 rule to the total daily dose. And again, it's looking at the background insulin. So again, looking at that possible 50 to 50 splits, that total daily dose divided by 2 to give you roughly what you'd expect to have as background insulin. And if they're on an insulin pump, you would divide that total again by 24, so you can get roughly what their average should be per hour on the basal rates. And once you've got that, this is for pump users, once you've got that average basal rate, does the basic shape or profile match what you would expect to see with the physiology of insulin? And if it doesn't, there needs to be a reason why it doesn't. And it needs to be a strong reason why it doesn't. You know, that most people's profiles with regards to an insulin pump should look very similar to what we have on the screen here, give or take a couple of percentage. Another thing that just from practice, I find that people don't look at in much detail is the active insulin time. So again, we've got more and more people going on to bolus calculators, whether on insulin injections or using the bolus calculators on insulin pumps. And again, there's good evidence to support that the active insulin time should be dominated according to the average size of the bolus. So if you've got somebody that's on maybe 1 to 4 units as an average bolus, then the active insulin time should be probably slightly less at 2.5 hours compared to somebody that's on an average of 8 units as a bolus, which will probably have an active insulin time of 4 hours. And again, that's different for people with chronic kidney disease, where we know the kidneys hold on to the insulin and we've got that longer duration of insulin. Our policy here at King's is that really everybody should be offered a bolus calculator and have the access to a free bolus calculator. Reasons for this, I think it really takes away the emotional decision making. It allows correction to the target level, and it also allows reverse corrections to keep the person within target level. It takes away, like I say, that emotional decision making, which when you really explore with people, those rage boluses that often go in when they're fed up with their blood glucose levels running high and then crashing are often emotionally linked. So it means that we can give corrections whilst keeping the person safe. And I always advise, this is a snapshot from the Diabetes M calculator. I always advise this calculator, particularly as we're seeing more and more people coming in with Libra, Dexcom, continuous glucose devices, so that again the adjustments can be made for the arrows. So I think that's really important. Another aspect that I would really kind of hone in on with regards to the consultation is with regards to the timing of the bolus. Again, there's really strong evidence around how that bolus needs to be upfront with the food, and a good 15 to 20 minutes upfront with the food where they can, and really going through the kind of benefits that people will get from that, and you know, really exploring. There was a paper that I read a little while ago which showed actually, but just by moving the timing of someone's bolus was actually able to bring their HbA1c down 1%. And if people are really struggling with that, again, we've got some of the rapid acting insulins that we can look at as an alternative if that's some of the issues that they are having. I've just shared with you a couple of downloads that I've kind of just cut and paste really, and this really shows where the timing of insulin can be very much an issue. So at the top here, you can see from the 10.1 to the 14.9, The 10.1 was clearly when they'd eaten, but the 14.9 was where they had given the meal insulin for the food that they were having. And because of the mismatch, you get that rapid decline. So you get that 45-degree rise with a rapid 45-degree drop. And you can see that in the pump download as well at the bottom, where the two areas are circled with that rapid rise and drop. So again, looking for that on the download, again, having that insulin up front with the food, having that bolus 10 to 15 more prevents that postprandial rise, prevents the stacking of the insulin, and again, protects that person from hypoglycemia. It's really important to point out as well that the bolus calculators will only be accurate in the event where they are having that insulin up front. So time and range, this is something that I found has been a really good motivational tool, actually, and it's something that we're seeing more and more frequently on downloads. And there is, really good evidence coming out to show that time in range is related to HbA1cs and linked then to reducing the risk of complications. And like I say, it really should be used as a motivation and not as a judgment. But just from my experience of using time in range, for the person who's living with diabetes, they really seem to just get it. It seems to be very realistic for them, really tangible target to understand. And a couple of the comments that I've had from somebody, this was a gentleman who was really, really struggling, and actually Libra transformed, his diabetes management. And we were looking at his time in range, and he said, 60%. And I was talking about, and I could see I'd lost him a little bit. He'd gone a little bit blank. And I said, well, what are you thinking? And he said, I only need to find 10%. I can do that. And that really kind of met with him. That really kind of landed with him as information. And someone else that I had, who was obviously very good at maths, because I couldn't do the hours, they were at 75% time in range. And they said, 18 hours a day, I'm actually within target. And they were really impressed with that. And somebody else who I had picked up the point that even though the target was less than 5% below target, which you hopefully are aware, they had 3% below target. And they worked out to them, they were still over an hour hypo per day. So that was the area that they then wanted to work with. So again, really using that as a motivational tool, I think really works and is something that people understand. I just wanted to share this case study story with you. This is when I had the kind of good, bad and ugly consultation. This was probably the ugly consultation. This is certainly one of the ones that I do certainly remember. So this is somebody with type 1 diabetes, diagnosed at the age of 2, and she really has traumatic memories of, she remembers people holding her down, going to give her injections when she was very, very young. She was referred to King's in 2012. Referral letter said poor glycemic control, recurrent DKA and depression. She had multiple health crises, which were being dealt locally with her community health team. And she actually lived quite far away from King's. She was over 2 hours drive away from King's. And as part of the initial assessment, when we started to look into the information a bit more, she actually had a recurrent history of self-harm and previous suicide. She really had the belief that basal insulin and long-acting insulin was not working for her, and she needed to have an insulin pump, and that was the reason she asked to be referred to King's. And she was actually started following a MGT decision. She was started on an insulin pump with some basal insulin underneath, again to protect us, given the fact that she's got a history of DKA. And there was a real joint approach at that point with the medical team and our local mental health team to ensure that any medications were optimised from the mental health side of things. And what we know from this person is that when her mental health was bad, her diabetes was bad. And she actually disappeared from our service for quite some time. She'd not been seen for over 18 months and missed kind of 4 appointments. Her pump was out of warranty. We were writing to her. She hadn't come back to us. I think the last letter was very much a kind of, please, you must attend. If you don't attend, we will stop your pump supplies. And we wrote a letter really to say we wanted you to attend to see how we could support you to enable you to continue using the pump safely. We were very aware, and as you can see from the download here, very few boluses, mainly running on the basals, no blood glucose monitoring. So we were very keen that this was a very risky situation to be, and was a risky situation to start with. So when we saw her, and I saw her actually with my colleague who's recently left King's, Dr. Pratik Chowdhury, we saw her together and we talked about how we could support her using the pump safely, possibly even having a pump holiday, and was really asking her what we could do to help. And I think both of us felt we were being very empathetic at that time. We knew that this was going to be quite a challenging consultation, by which point she actually pulled her pump off, threw it at us across the room, shouted, stormed out of the room saying that I'm going to go into DKA and run out of the department. As you can imagine, we did run after her, but she was quicker than us, and we couldn't catch up with her. And given her history, we were very worried about both her mental and physical health, about what would happen when she had no insulin. So at this point, she had no background insulin. She was working purely on pump. So we come up with a plan and we called the local hospitals and we spoke with the local teams. We arranged for degludec and Novorapid to be available for her, both at the diabetes centre and at her GP practice. And we really very carefully wrote out an email to her apologising for how the consultation had gone, that it had gone not as we had planned, and that we were there to help her. We really wanted to reach out to her and help her, and that we did have a plan to get her back onto the pump, and we really wanted her to come and speak to us. And so she did come back, and we actually did a series of joint appointments with the diabetes consultant at the time, myself, and the psychiatrist. And the psychiatrist there was really there to enable us to re-establish a relationship back, because we've just felt that relationship had actually been torn to pieces, and to equally facilitate the negotiation between us and the person with diabetes, so that we could move forward in her diabetes management in a positive way. So she did have a couple of psychiatric appointments with our psychiatrist here, just really to reflect on what the challenges were with the diabetes and the problems that she was having with us as a team. But again, her main mental health was being kept with her local team. As agreed, we started her on Dexcom with degludec and Novorapid. This was something she didn't want to do, but I said, you know, this was very much about rebuilding the processes of diabetes management. We weren't worried about the blood glucose levels. We wanted to build the processes back in so that she would be safe on an insulin pump. And I'm quite sure you can see from the screen here, there were many issues with timing of her insulin, with overtreating of highs and lows. She had huge areas of lipohypertrophy as well. But to her, again, we still hadn't got through that, you know, to her, it was the background insulin that was the biggest issue. She felt that didn't work and needed to be put onto an insulin pump, which we agreed. If we could see that she was measuring, we could see that she was reacting and engaging with therapy, we would move then over to an insulin pump, which is what we did do. We moved her actually onto Control IQ, the tandem T-Slim pump with Control IQ. And here you can see the results for yourself. 86% time in range, really happy with her overall control. She was using exercise mode. We discussed actually the last consultation I had with her, I actually discussed, she was really pleased, so pleased with how things were going. She kept aiming for 100% time in range. And we had to speak about, you know, the expectations of that. And, you know, this has now been long going. So this is now over 2 years that she's been achieving this control. And I suppose what our learning from that consultation was how important those psychological skills were, challenging, reinforcing, supporting, emphasizing with. The learning that we had, you know, again, it wasn't, we don't all get it right. We do still have those bad consultations, but making sure we're still reaching out to people to see how we can support them. And what I wanted to share with you was possibly some of the resources just in the last minute, just with some of the resources that are available, because I think that's often some of the problems, isn't it? We don't have the resources, and these resources are available in your own time. They're recorded. So via Academy, via Gluco, You've got lots of videos, some of which include virtual consultation skills, pumps, data management, interpreting data, using CGM, using pump, all of which are available via the DTN. All of the calculations, because I know I've gone through that really quickly today, are all available on our best practice guides through the Diabetes Technology Network as well, all of which are, you've got links here as well. And this was something that I found, this is a psych discussion that's happening, a webinar. It's actually a series of 5 free 1-hour webinar with some fantastic speakers as well. So again, I would say to you that if this is an area that you think you really need support and help with, reach out to some of these resources to kind of build your confidence, build your skills, and to see where you know, to keep supporting the people that we're all here to support, really. So I've really had to kind of whistle through that because of some of the technical problems. So apologies around that, but I'm more than happy to take on any questions that may have come through, Sue.
Oh, Geraldine, that was amazing. And some of the, I mean, I've scribbled down just some of the terminology that you've used, and it's like, my goodness, this so resonates, And I have to say, the work that you do in the technology network, the resources that are available are just phenomenal. I mean, I send everybody to them, patients, healthcare professionals, you know, literally just go and see what's there, because I think it's just an exceptional resource. So well done.
And the resources that we need in our own service, it's not that we've got it all right, don't get me wrong, the resources that we develop, because we're also needing those resources. Yeah. And we're very, very clear that, you know, there are lots of DSNs out there working on their own, very silo working, you know, that maybe don't have as much team support. And really the idea when we developed these resources was that they were available for everyone, regardless of where you worked. So that was the idea for them. So and please use them and share them.
Yeah, but that's why I think they go down so well, because they absolutely relate to everybody who's trying to do this, you know. And it's like you say, when we're all starting to look at all of this data, and certainly when I speak to people, you know, it's that can be overwhelming. But I think one of your slides as well said, you know, the one thing to do is, or certainly what I hold on to, is we're just still trying to look for pattern, for causes of the pattern, to try and improve things. And just because the data is coming at us in such a different way, that's still what we're there to do. And so I like the fact that you separated that out into, you know, is this a technical issue? Is this a behavioural type issue?
Yeah. And unfortunately, because of what we needed to cover in today's session, what I really wanted to do is how I would go through that in you know, this is the person, this is their total daily dose, how I would look through the different downloads. And that might be another session, because I think once you've got those basic skills, actually you hone in quite quickly on the information that you need. You come to your hypothesis actually really quickly. And then when I talk about meeting the patient, you can then really understand why maybe sometimes they're doing the things that they're doing. So if their carb ratio is completely wrong, for example, you can see why then someone would be moving the timing of their bolus, because, you know, every time they gave it, they were hypoing. So they needed to make sure that their blood sugar were rising. So that's where I talk about really meeting someone so that you can put those two relationships together.
And I loved your terminology, the rage boluses. I've never heard that before, but it's like, oh my God, that is exactly, you know, and because I also run a pregnancy clinic, and I can see people are driven to have this increased time in range. And so all they do is they're just over injecting all the time. And I spend so much of my time, but also helping them see from their readout actually where they're doing that.
Yeah. I spoke to somebody just last week who was on injections actually, and he was following football, his blood sugar levels, I think it was a football match, it was quite stressful, I think lots of other things had happened, and he just couldn't get his blood glucose levels down. And his description to me was he just flicked the pen, in it went, didn't know what dose it was, just to get the blood glucose levels down. And it's really kind of, you know, that's where I think those bolus calculators, because it takes away that emotional decision, you know, that they don't have the emotions attached.
Yeah, absolutely. But I will hold on to that rage bolusing. But one person did say and has asked, which bolus calculator do you use mainly?
Diabetes M. without question. I think that for me is the one. You know, I used to love the interlinks. That was, you know, why that is locked on a calculator, which I've brought up with Abbott many a time. I do not understand, because I think, again, that would be really useful for a lot of people who can't access the apps. But the fact that you've got the fine-tuning element with the arrows, because we're seeing more and more people, aren't we, coming through on Libra and continuous glucose monitoring. The fact that you've got that fine-tuning and it's free, for me, without fail, that's the one that I'd recommend each time.
Brilliant. Another couple of questions, just going back right at the start of your talk, you were talking about the consultation tool, and somebody has asked, is that used in a PED service? Can it be used with children? Or is it more of an adult one?
It was developed for an adult service. I can't see why it couldn't, because the care processes are the same. The assessment of structured education, the assessment of severe hyperglycemia, DKA, education, carb counting confidence is all the same. DDS2 is now used in pediatrics. So I can't see why it couldn't be used, but it was initially developed for adult services. And I know just from different talks that we've done, that there are many areas, you know, although it was developed under the HIN and it's accessed via the HIN network website, there are many centres across the country that are using it, and even international centres as well.
That's brilliant. So Hayley, I hope that's answered your question. Teresa's just come back about the bolus calculator question. Is it licensed for peds?
Diabetes M, I don't know. I know that they do advise. My sugar, I think, is more from experience with and discussions that I've had with pediatrics. A lot of them are using the My Sugar, is my understanding, but you'd need to have a look, because it does look, you have to put in weight and things like that, which can be a little bit different for pediatrics.
And might be, absolutely, that's what I'd say. So yeah, there are no more actual questions, but I just want to say, you know, some of what you've gone through, I mean, that really was a whistle-stop tour.
It is. You could spend a whole day actually on those two topics alone.
But I just want to pick up as well where you put up the time and range, and you sort of said how it really resonates with patients. And yeah, I absolutely echo that. I have people coming in who actually take screenshots of it one week when it's a certain percentage, because by the time they get to see me, maybe that percentage has dropped a bit, and they want to prove to me what it was like. And it is, you know, like so many things in diabetes, once something resonates with the person, then it starts to really have an impact. And I think that's the complete change that we've got here. This isn't about books of numbers and recordings and how many tests you can do. This is visual. This is, I think you use the word intuitive, and that's certainly what I've found working with people.
Just words of somebody with diabetes in clinic, when we were discussing the time in range, we were discussing kind of expectations and, you know, where we'd like them to be. And he described it as, I've got a 30% allowance. So he saw himself, I've got a 30% allowance. So for those times where, you know, I guesstimate my carbs, for those times where stress pushes my blood glucose levels up, or it is a little bit more erratic with sport and things like that, that is my 30% allowance. So if I can do what I need to do to get the 70% and reduce the hypos, I know that those, and just for him, that gave him acceptance that it was okay to have still highs. And I think there is now, isn't there, because people are seeing those 100% days or 80% days, kind of going through the kind of expectations of, you know, and trying then not to create burnout in the other direction, really.
And I think very quickly, bringing this back to the art of consultation, the bit that I loved, and my mantra is, remember, there's always a person behind that data, because with that sort of data, nothing's hidden, is it? Nothing gets hidden.
And that's why I think it's so important to really hone in on your interpretation of data skills, because you want to spend that time speaking to the person in front of you, not looking at another screen, not looking at purely the numbers, really kind of, and you really know, you know, when things land with someone, you really know. And that's where I talk about meetings, that, you know, I'll often draw that, well, what happens here? How do you feel with that? What happens then with your blood glucose? What are you thinking? What are you feeling? And we actually try so that we can really meet what's happening. And only when you can do that, I think then you can look at making the change.
And one final thing that's just come in the chat, do you have anywhere that you recommend people go to increase their skills in motivational interviewing?
So I know there is a webinar on the DTN website. I know I shared the videos, but we also have got webinars on there. And Nicole D'Souza did a really good webinar on motivational interviewing. So I'm worth recommending that. I know SLAM as well are developing a course for diabetes nurses and nurses in general, but in diabetes per se, around motivational interviewing. And again, that webinar that I've showed, that will cover motivational interviewing as well.
Brilliant. Well, listen, that's brought us to the end. The time has flown by. Thank you so much. It was really, really great to listen to you.
So thank you all for attending again, and thank you, Geraldine and Sue, for a brilliant webinar.
Thank you.
Right. Thanks, everyone.